Yes, hear you very well.
Great. Thanks for having me. I am at the University of Colorado in the Center for Bioethics. I'm a practicing internist and also a PhD philosophy-trained bioethicist. I hope to bring those lenses into my view of some of the issues that come up with ethics, bias, and the adoption of AI in medicine. No relevant conflicts to disclose. That's where I've had research funding. Today, I really want to touch briefly on just three issues, the big ones: privacy, bias, potential impacts on choice of the use of AI in the clinical context. And I'll close by touching briefly on some of the bigger picture issues. Some of these issues actually will echo what's been in the prior two presentations, and maybe if there's time left or later today, there'll be time to discuss some of these amongst each others. Of course, plenty of issues that we can't discuss, medical error, autonomous systems, stigmatization, and so on, but let's just talk about what we can. So I don't really need to tell this audience that AI use cases are appearing across the translational research spectrum and also across a diversity of clinical uses, from R&D and early phase studies all the way to public health surveillance. We could talk about ethics in any one of these particular contexts. I also don't need to harp on the fact that there are questions about whether AI will live up to the hype, with up to $6 billion in investment, dozens of recent FDA approvals within the past few years, and approvals is in scare quotes intentionally because it's not exactly clear what approval means in this context from a regulatory perspective, and an exponential increase here just showing numbers of publications on machine learning by year in PubMed. But of course, with this promise comes peril. We've probably all seen news stories about IBM's Watson making unsafe and incorrect cancer treatment recommendations. You may have caught the news story of Google and the University of Chicago being sued over aspects of data sharing. So clearly ethical risk involved as we move AI into the clinical implementation stage. Now, this is a complicated slide, but it makes really what I think is a simple point, and that is that how we think about and how we manage ethics issues are a key part of the implementation context. So in this figure, you've got the black and gray boxes, which are the context of implementing an intervention into a healthcare organization. I've overlaid ethics concepts, which are underlined, just to show you how ethics concepts, when you integrate them with dissemination implementation, can help be predictors for what's on the lower half of the slide: adoption, implementation, maintenance, and eventually reach and effectiveness. So ethics is a key part of the implementation context. So let's talk about a few of these issues. As I said, we'll talk about three, and we'll start with the big one, which is privacy. Now, a lot of the talk about privacy relates to use of EHR data, claims data, and so on. And those data are complicated enough, but I want to push us to think a little bit more future-oriented, because in my view, as attention turns to addressing social determinants of health, linking data across sources will be ever more important for us to address the underlying root causes of ill health. So there's a recent NAM report that emphasizes and notes that HHS has proposed regulations that promote greater use of third parties that will aggregate data across systems to create longitudinal health records. And that could also incorporate social care data. And we've been involved in projects that attempt to do this. They attempt to link health information with housing data, with food bank data, with emergency service data, and so on. And you can imagine that it starts to get really complex from an ethics and a legal perspective, what it means when you're linking and sharing data across these very different contexts. It's also been hinted at in one of the earlier presentations, the idea of privacy issues and AI-powered surveillance. Obviously, many of us are thinking about the coronavirus pandemic now, and if you look do any reasonable search around mobile phone apps and contact tracing, you'll find that there are concerns about privacy related to the use of mobile apps. Here's a case study from South Korea where, although the data themselves were de-identified, people who were users of the data could actually connect the dots in a certain way and be able to identify contacts with whom they were exposed, sometimes revealing potentially sensitive or stigmatizing information about some of these individuals' behavior. But of course, it's not just In the coronavirus context where we see this, this is a project at Stanford that's looking at vision-based smart hospitals. You can see taking computer analytics, overlaying video images, in this case, to look at hand hygiene, right? To understand whether individuals, physicians, other healthcare professionals are washing their hands in and out of patient rooms. Now, in a nod to my philosopher side, some of us, including Glenn Cohen at Harvard, have compared these sorts of systems to Jeremy Bentham's Panopticon, which was an 18th century ideal prison where you can see the design is such that prisoners are under constant observation. It's a circular design with an observer in the center continually watching prisoners. And of course, many people, you imagine, find this image frightening. What does privacy mean from an ethics standpoint? Well, there's an influential view of privacy that looks at privacy in context. And I think what it means in the age of AI is that with increasingly large data sets and their integration, this idea of de-identification, let alone anonymization, may simply not be possible. And this influential scholarship emphasizes that privacy is context dependent. That is, our expectations about who can see or use our information vary. We have different expectations about an examination room versus an online shopping site, for example. And privacy involves access, control, and use over this information. So here the issue is more data context than it is data type. And achieving the right balance is by no means clear. This came up in the presentation just before me. Across context, you could say which privacy expectation matters. Do we look for a least common denominator? Remember that slide about food banks, emergency services, housing, and healthcare. Do we look for a least common denominator and apply it across those contexts? Will centralized third-party methods or decentralized methods that put the data on the device be best for achieving this balance about privacy? Lots of unanswered questions, even if we assume that this contextual view of privacy is really important. Now, I'm actually somewhat optimistic that we have the technological fixes for privacy and that we can do this. And so what I want to point out is that it's critical to recognize privacy is not just about privacy. How we manage privacy can actually affect issues of justice, that is, the distribution of benefits and burdens within society. Suppose we have a privacy protecting record linkage, a PPRL, whether it's deterministic, probabilistic, or mixed, as one of the systems is here at the University of Colorado. Now, suppose this performs differently in linkage between different groups, between minority and vulnerable populations, for example. What this would mean is that the benefits and or risks of these linkage technologies could be distributed unequally. And anytime the benefits or risks are unequally distributed, there's a potential for inequity, that is a moral judgment about justice. It includes if and when certain groups choose to opt out because of distrust. So who gets impacted by our linkage technology intersects important issues of justice. I won't dwell on this particular slide, but there is a notion of privacy by design that lists out certain principles that can be used throughout the design lifecycle to guide and shape how privacy is implemented and operationalized. It involves conducting privacy risk assessments. As was just pointed out, there needs to be a societal notion, or at least a common notion, about what level of risk is acceptable. And it also includes things like protecting all the way through re-identification. If you've not seen privacy by design, really important, encourage you to look it up. All right, let's talk briefly about a second issue. It is bias and resource allocation. Lots of examples coming out on racial biases and algorithms in healthcare. Here's a highly cited important example in the journal Science, where the health of populations directs resources to one group over another in a racially biased manner. This paper describes a system where case management resources are given to for the sake of early discharge and are given preferentially to white patients over Black patients, thankfully not actually implemented once this was recognized. And even concerns about biases in the algorithms that allocate resources during crisis standards of care when or if we have to ration during the coronavirus pandemic. Why are biases like these so problematic? Well, the models are built on historical data, which reflect long-standing and horrific biases in the system. These models can be biased even when particular variables in question are not even used in the model, so even if race is not included. And then for adaptive systems, models that start fair can learn from ongoing biases in the system and then become unfair over time. So for example, if you had an AI-based model about COVID survival, it could easily learn that African Americans have greater mortality and then recommend resources go elsewhere to maximize the lives saved. And yet, most importantly, I think it's really key to point out these models make one of the most critical ethical decisions in healthcare, and that is who gets what. So what do we do about biases? Well, with the co-author, we've proposed this notion of recognizing latent biases in the system, that is biases that are waiting to happen. We think it's important to recognize that even a perfect model can become biased over time. We think we should conceptualize bias itself as a safety issue that must be addressed ex ante and can't wait to be addressed later. We have to actively monitor for biases over time, not wait for them to be exposed in the scientific literature. And importantly, engage all stakeholders in AI decision-making to avoid bias in the choice of AI tasks. We'll talk about that just briefly in the bigger picture section. All right, third issue. I want to talk briefly about AI at the bedside, putting on for now my clinician hat. So one recent example of AI being used at the bedside is to identify patients who could benefit from early palliative care based on a high risk of mortality. I show you here just one of these systems. Others have been used, implemented at the University of Pennsylvania, at least in research studies. But how do we think about this? Well, as a clinician, I think we have to find the right balance between clinicians under-relying and over-relying on a particular AI system. Under-reliance is when clinicians don't use it when it's needed, when they perceive a lack of transparency or explainability of the system, and those are two distinct concepts, when they're overly concerned about one-time or rare errors, when they worry about biases, or when they only use, when I as a clinician only decide to use the AI for certain patients. Clinicians might also over-rely on AI. They might defer to it because of ever limited time in patient care. They might follow AI-based recommendations for fear of legal liability if they override it. Or they might reduce the decision, in this case about palliative care and end-of-life care, only to one of mortality when it's actually a multivariable concept. And just as a note, this over-reliance is what I would call de facto autonomous AI. It may not have set out to be autonomous, but if in practice clinicians treat it as such, then it becomes de facto autonomous AI. And there's also a general concern, I would say, about whether AI will change how clinicians like myself view responsibility for a decision or complicity with an error. Just briefly, the issue of choice is not just about clinicians, of course. There are questions about whether patients have a right to know that AI was used in their care as part of informed consent. Is there something fundamentally different about a human decision compared to a machine one that requires greater justification or explanation to patients there at the bedside, and so on. I want to close with just a couple comments about the bigger picture. And this has already come up today, and it's the question of what is an appropriate use for AI. This is an important viewpoint perspective about asking the question, if AI is an answer, what should be the question in the first place? And you can see here, Dancel Macy says, AI will not reduce the uncertainty inherent in making ethical decisions. There's no technological solution to the riddle of death, reflecting on that AI algorithm I just described to you, and so on. The concern here that algorithms exercise tyranny over the true freedom of moral agency that we claim to be respecting. So what is an appropriate use for AI? Big picture comment number 2, can we retreat to saying AI is simply a tool, like a surgeon's scalpel? On the one hand, things we use to achieve our ends. But there are other perspectives on this, and Heidegger says that tools, in fact, fundamentally change the way we see the world, even changing our end goals in ways that we may or may not recognize. And in fact, scholarship in sociology points out that the tools we use can change the way we think and the way we act towards each other. And if this is true, if the use of these sorts of tools can really change the way we think and act, particularly related to values, it has significant implications for ethics. So it's not just that we need ethics to inform our use of tools, we have to be aware of how these core values, privacy, choice, and others, affect each other. And just as a sobering reminder, I might point out that informatics, statistics, and so on played a prominent role in the Holocaust. If you're not aware of this story, I encourage you to look into it, that some of the statistical methods and packages that were used then really facilitated the Third Reich's regime. So I'll conclude with just a couple thoughts. AI, as I said, has great potential, but we have to understand the potential for ethical issues and unintended consequences as well. It's critical that how ethical issues are managed creates a key part of the implementation context into healthcare. Ethics can affect adoption of new technologies. As AI moves forward, I think there's a great need for research at the intersection of ethics and implementation science to monitor for these consequences, develop ways of mitigating them. And when we do, a last big picture comment, we have to be on guard for avoiding AI exceptionalism. That is, the idea that AI is fundamentally different or unique. It may be in certain ways or others, we could discuss that, but we've learned from history related to HIV exceptionalism and genetic exceptionalism that claims of something being purely exceptional or purely new and required significantly different treatment are dubious at best. So I'll stop there. I appreciate your time and hope maybe there's time for one or more questions for the panel.
All right, thank you very much, Dr. DeCamp. Do we have any immediate questions? I know we covered a lot of deep thoughts here.
Sorry to rush too. I know I was trying to get us back on time, which I think we did.
Yeah, perfect, fine. Okay, we just got one in here. As a clinician, how would you use AI with your patients?
That's a great question. You know, I tend to be on the side of, for example, let's take the question of informing patients or not. I tend to be more on the side of informing patients that it's used or not. Now, I've been pressed on that, right? EKG machines are read in an automated fashion and will give at least a preliminary readout of an electrocardiogram. But I feel compelled to discuss that with the patient, and I would feel the same way about a particular AI technology, you know, whether or not it's unique. So I certainly see the advantages of using AI to inform clinical decision-making, while fully recognize that a lot of those risks are certainly present, risks of over-reliance or under-reliance in everyday practice. I hope that kind of answers the question. A lot of it also really depends on the use case.